Hi, and welcome to the show. Rate and review at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today, we welcome back on the show Maha Al-Ghafry. She's a pediatric hematologist-oncologist. Her Kevin MD article is titled The Merry-Go-Round of Rounding. Maha, welcome back to the show.
Thank you so much, Kevin. I really appreciate everything that you do and for really giving physicians a voice.
Well, thank you so much for coming back on the show. Now, for those who didn't get a chance to listen to our first episode together a few months ago, just briefly share your story and journey.
Yeah, so I am a pediatric hematologist. I did my training, pediatric residency training in Alabama, went to New York to do pediatric hematology oncology, and then also did a year of transfusion medicine. And now I practice back home in Oman in the Middle East.
All right. So you're in Oman now. Tell me about your practice and what medicine is like in Oman.
Surprisingly, and after we'll get into our article, it's very similar to how it was in the US in a lot of ways. The nuances of availabilities of certain things are a little bit different, but one of the nice things is we do have universal health care, so you can even get your ibuprofen from the hospital on your way out for free, which is really different kind of from the practice in the US.
All right. So walk us through a typical day. Tell us some of the typical cases that you would see as a pediatric hematologist oncologist.
Yeah, so my clinical practice is mostly focused on pediatric hematology, both non-malignant and malignant, so mostly leukemias. And the non-malignant would be kind of your hemoglobinopathies like sickle cell disease, beta thalassemia, thrombosis, bleeding issues like hemophilia, aplastic anemia, typical iron deficiency anemia, and so on. And like a lot of people, I have a hybrid of inpatient service. So you're seeing the patients that are admitted to the hospital, kind of consults or anybody else from the other disciplines or the ER, and as well as outpatient clinical practice as well.
Now, what is it about pediatric hematology oncology that drew you to the field?
Yeah, so in residency, I knew that I wanted to subspecialize, and I really loved how rooted pediatric hematology is in general pediatrics, especially kind of looking at everything from basic neutropenia, basic anemias, basic, immune thrombocytopenic purpura. That's all a lot of basic pediatric care that I felt that I got a lot of strong training in. And I really kind of love that intersection between where it's something we can call non-malignant, like sickle cell disease, but like the myriad of implications and complications that a disease like that can have for the rest of a person's life, and then the intersection with oncology. So that's what drew me in.
So by definition, you're seeing a lot of kids that have pretty severe disease. Some of them can be, of course, pretty sick just by nature of the conditions that you see every day. How difficult is it as a physician to see that? Because a lot of people outside of medicine, they can't even imagine their own child going through something like this. But as a physician, you see a lot of kids who have pretty severe conditions. Talk us about that. How difficult is it for you to see that?
It's really difficult. And I think one of the things that I'd like to point out is that it's the patients that have an oncologic diagnosis like leukemia, like osteosarcoma, for example, with a very definitive treatment plan and what they're going to go through. A lot of those parents and families are kind of, even if they are hesitant about understanding this whole new world of our oncology and trusting you with that, they get it, and you can move along with the treatment plans. Where it becomes a little bit difficult are those really gray spaces in hematology, things like thrombocytopenia or neutropenia that are in general not in and of it themselves concern for a malignant problem, but the parents, they will Google, go online and ask people, and they're just worried, this is leukemia, this is leukemia, this is leukemia, no matter what you kind of explain about immune thrombocytopenic purpura, and chronic, ethnic, I don't like that word, but ethnic neutropenia, for example, and then more of the spectrum of kind of the aplastic anemia, myelodysplastic syndrome, where those are just it's very difficult to diagnose those conditions, and sometimes it takes months to make sure that you hit all the criteria, and the treatment plans kind of differ a little bit, and they are very, very rare cases compared to even some of the oncologic processes. So having families on board and really trusting what you're saying is kind of the difficult process of the whole situation. But as with a lot of things in medicine, like you really get to know the families really well, you get to know the patients really well. And as a pediatrician, I feel like our connection, or at least for me, a lot of my connection is with the parents actually, rather than the child, because it's difficult for the child to connect to you. They're connecting with their parents, but the parents are the ones connecting to you.
Now, we have a lot of medical students who listen to this podcast. What kind of questions should they ask themselves if they perhaps may be interested in pediatric hematology oncology?
Oh goodness, lots of things. I think that there is, in pediatric hematology oncology right now, is still a combined field. If you are, as a medical student, are interested more in non-malignant hematology, for example, in adult medicine, internal medicine, you are able to, for example, go to hematology only fellowship, for example, rather than doing combined programs and only taking the boards for hematology. So I think that's one of the things to kind of stop and think about. Like, do you want to do the combination of both? Or if you like just one of them, then maybe go to the adult side, just kind of thinking as a medical student. And then from there on, like, just recognize that this is definitely going to be a field where you have a lot of multidisciplinary care. It's not just you. You're going to have to work with the pathologists, with the intensive care doctors, with all sorts of surgeons, orthopedic surgeons for osteosarcomas and so on, and pathologists, etc. So it's really, you really need to be able to work with different teams, work within your own division really well to make sure that you're providing appropriate care for these patients and keeping up with a lot of the rapid rate of increased, thankfully, data that we have on a lot of things that we didn't have available before.
All right, so let's talk about your Kevin MD article. It's titled The Merry-Go-Round of Rounding. Now, how did this article come together?
I think at the bottom of the article I wrote, the alternate titles were I Hate Rounding and How to Not Make Rounding suck. And this is something that I've, felt, it's not because of my current practice as an attending, but that I've, thought about all throughout my training. And since I was a medical student, rounding is a beast, especially as a resident and as a fellow. You're in there in the mornings. I kind of go through, like what a typical inpatient day looks like. And I'm not going to hit on the surgical field because I know, they start rounding at 5 a.m., which is absolutely insane. But, you're the whole point of kind of rounds is to collect patient information and disseminate patient information and to come up with management plans. And it seems like the whole day you're just rounding. You're rounding with yourself, you're rounding with other team members, you're rounding with the nurses, you're rounding with your attending, you're rounding with social work and case management. At the end of the day, you're rounding with, the unit receptionist trying to get things done for a patient to be discharged, for example. There's just a lot of things that go into inpatient medicine, with kind of rounding being the cornerstone of that. And I've tried to search, where does this word come from? Does it come from physically going, the John Hopkins like famed dome of people going around, and that's where it started. But to me, rounds do seem never ending, honestly. Like, you start your day and end your day with just going round and round with patient information that you have. Yeah.
Well, so go into more details. I think that you mentioned earlier, you said rounding is a beast, and it's been a while since I've done inpatient medicine, but I could imagine as a resident, rounds would take, sometimes 3, 4, 5 hours, depending on how the attending was, depending on how patients you have. So from your experience, when you're training or even now, just take us into one of your rounds. Like, what's it like?
Yeah. So, I kind of, let's think back to my experience as a fellow. This was definitely making sure that you come in, at 6:30 a.m. when it's still quiet. There had no handoff hasn't happened yet. The nurses haven't given their handoff yet. So nobody's disturbing you quite yet. Kind of set the tone for your day. And by pre-rounding, I mean, like, you're sitting down, of course, at your computer, looking at all the patient information, seeing any active issues that happened overnight, checking that your patients receive, certain medications, any consults that might have come in, and so on. And then you go into kind of your formal rounds, and those are very, person specific, institution and attending specific. Are you going to have the typical sit down rounds with the computers? Are you going to have walk rounds with a computer, like the computer on wheels? Are you going to have patient centered rounds? I know maybe I feel like a little bit more of a pediatric, where you don't say anything, but you like physically just walk into the patient's room and you start talking giving your rounding presentation with the parents. That's its own thing. So these different types of like traditional typical rounds, where you're the team with the attending, whether it's residents or fellows or advanced practice providers, usually that's the core team. But then are you including other people in that rounding? I personally love it when we are able to have nurses within our rounds. They give you such a breadth of information that you just can't get with going through the computer by yourself or talking to each other. because, they'll tell you how, thick the NGT aspirate was or something, or if they're having a difficulty taking a specific medication. So do you need to speak with a pharmacist about compounding it differently and so on. So these are the kinds of aspects of rounds that, you need to take into account. Now, within our healthcare system, it's really the problem with rounds is rounds can't last all day. Like ideally, they would take as long as they need to take for you to speak with everybody that you need to speak to speak with the family, also to physically review every single medication that is ordered and whether it's been administered or not, any PRN medications that were administered or not. How does, because if somebody's getting, morphine as needed every 3 hours, then maybe you need to be doing something else, right? And those are the little nuances that can get missed even in detailed rounds. Do you have a clinical pharmacist that is helping you with any kind of drug to drug interactions? So kind of that's number one, who are the members of the rounding team that you have with you, other than the clinicians that are seeing the patients? You including nurses, clinical pharmacists, and or parents in this discussion. And then the next layer comes to, great, now you've done all of this work, like while you're rounding, is somebody there putting in orders, putting in consults, doing any of the additional little work? If you're not doing that and you're, finished 5 hours of rounding and then you have the intern go off to put in, medication changes, anything else like that, that's delaying when you're able to get to, completing any of your tasks. And then we're not even going to include, for example, speaking to other services within the hospital. Do you need to consult, the GI team, the respiratory team? Who else do you need to include in this patient's care? In addition to, as I had already mentioned, for example, case management or social work, how are we going to get this person home? So as you can see, after your official rounds and you're putting in your orders and, writing your notes and so on, and then you get to a point where, almost time to hand off your patients, and now you're doing another kind of mini round with your handoff in the afternoon. And I remember that for me as a fellow, I used the handoff as a checklist of like, did we make sure that we did everything that we said that we're going to do? So that's another, like, that's your third rounds for the day, essentially. But clinical medicine has, evolved to be this like behemoth that is in a way untamable, but also it's very necessary for us to do all the things that we used to do. I like to say that, 50 years ago, we, barely knew how to treat leukemia, right? We had like a couple of drugs and that was it. But now we have, from your basic first lines to your second lines to your third lines, you have, and all the side effects that come from all of those different treatments that you really have to be on top of, and you have to have a whole medical team involved in taking care of that. So that is the kind of gist of inpatient rounding. It's not just about you and the patients, it's about you, the rest of your team and extended team, and making sure things are done at the end of the day. And it's very difficult within the time frame that you have. You only have 24 hours in the day to get anything done, but hopefully within your 12-hour or so shift, you're able to get that done. And if not, you're going to be going home and finishing up notes, right? To get things done.
Well, I'm dating myself here because when I did inpatient rounds, that was like 20 years ago. That was before the advent of electronic health records. So talk about that intersection between technology and roundings. I'm a primary care physician, and the computer sometimes can be a pretty big distraction in the exam room, in that it distracts and the attention of the physician away from the patient. The physicians mostly focus on computers. Now, when you did inpatient rounds as a resident or fellow, or even now, tell us about that third entity in the rounds, the computer. How does that affect the communication and the interaction that you have with patients?
It really depends. If we're talking about kind of inpatient rounds, if you are going around rounding with a computer on wheels, sometimes you can maybe have somebody else look up information if the parent has. So I personally think, having an electronic health record is very useful in terms of being able to see certain trends of things, really being able to see what medications were given, what was not given in a mobile form. It's also, I haven't really worked with kind of round, paper charts rounds or something like that. So it's difficult for me to kind of see the possible advantages of that. At least you have a little bit more consolidated information. Maybe things are laid out a little bit differently, or maybe in one page. I know that, for example, like the ICUs actually still, some ICUs will use, like paper charts, but whereas in the medical health record, you have to go through so many different tabs to find what you need, right? And then your note will, auto-populate with the like range of vital signs. But if you're not looking at the vital signs themselves, then you might miss key aspects of that. Like, sure, the range was, of temperature was 100 to 103, but if the patient is sitting in the 100 to 103, except for that 100.0 temperature, then that's something significant, right? So there's a lot of aspects of the health record that can also, although it's trying to make life easier, but it can also, if we don't dig in to every single little aspect, you can miss important information. And it also, the good and the bad part, which I'd already mentioned, is you can take work home, right? If with paper charts, you're just writing things down, and whatever is done by that end of the day. But with electronic health records, you're sitting there at home, you're looking back on things, you're editing things, you're finishing things up, you're adding addendums, and so on. So the work never finishes with having an electronic health record in that aspect. But I think overall, it is important to allow people from, especially, for example, I've mostly worked in places where you have everybody in one place. But if you're a physician that covers multiple different hospitals, it's really useful to be able to see that from, your hospital, to monitor things from afar before, for example, having to come and to see a patient and so on. Also, you're able to, if you're on call at home, as a fellow, this was definitely something that was really important, because we weren't in-house, but we might as well have been because of the hours that you were up all night, right? But it's important for you to, actually physically go into the patient's charts and see what's happening to them in the emergency department, in the inpatient unit, have a little bit more history, because, if you have a patient that shows up in the ER, if they're not trained in hemonc, they're not really going to be able to tell you the nuances of what chemotherapy they received how many days ago. And you're the one that's going to have to know that, so for you to know where exactly they are in their cycle, what have they received recently, are they on certain medications at home right now, that's going to change your differential diagnosis of what they're coming in for, and make you, adjust your management plan. So it's a curse for sure, I would say, because of the amount of information that's available. But I don't believe that modern medicine can, at the rate that we're going, can survive with, paper charts.
Now, you said earlier that if we're not careful, we could literally spend a whole day rounding. Now, if you were in charge, what kind of changes would you make to the rounding system to make them more effective and more efficient?
Yes. So I'm definitely a type A person. I like order. I like things to have a system-wise approach. So I think the kind of haphazard way of having, different people like, wanting to do things in different ways, by that, I mean, either attendings or residents or APPs, it makes it difficult to have uniformity and to have a consensus on the patient. So what I prefer is that for example, let's say when people are pre-rounding, if you have a pre-rounding sheet, for example, that is already laid out in a way that you will present in that kind of way in rounds, and everybody knows that this is what's going to happen in the presentation. For example, that they're going to discuss, give you the patient's one-liner, give you overnight events, give you vital signs, and then go system by system. Then you make sure that you don't miss anything. And I think that's the biggest thing when we're going in a haphazard manner and everybody's trying to do, some sort of a soap type rounds, or problem list based kind of rounds. You miss a lot of things, because if you're not discussing, for example, in line access for hematology, that's really, in oncology, that's really important, because it's not in your list, then you're going to forget that this patient, that is undergoing a transplant and has a double lumen Broviac, also actually has a unaccessed port line from, their initial leukemia diagnosis, and they, just spiked the fever. So you need to make sure that you're culturing every single one of those lines. But if you're not in your rounds, making sure that everybody's on the same page of what is going on with this patient to that level of detail, there are a lot of things that can be missed later on. But, when something happens to the patient, like, spiking a fever, and you have this extra line that is hidden under their skin and you don't know anything about. So that would be number one, would be making sure that everybody is on the same page about rounding in a very specific way, to allow everybody to be on the same page and to not miss anything. And also, I'll, I some people's arguments is that, going through every single system that takes longer. Just saying the patient is on room air and moving on does not really make anything longer.
Yeah.
The number of times that, during residency and fellowship and now people have missed, oh, by the way, this patient is on, 1 liter of oxygen. That's significant.
Yeah.
Because they went all off on, the fever that happened, all the antimicrobial changes that happened, and, they were a little bit hypotensive and you gave them a bolus and so on. And, you walk into the room and the patient is on oxygen. You're like, okay, well, it looks bad on the team that you don't know that level of information, right? So it's really about making sure you're doing things in a safe way, systematic way. And if everybody's doing the same thing, it is better for everybody. I really love the book by Atul Gawande, the Checklist Manifesto,
Yeah.
because even in the ORs and other places, having, checklists or systems in place, that it makes it safer for everybody to be on the same page and to make sure that the appropriate things are being done for patients.
And my final question, just tell us some of your take-home messages that you want to leave with the Kevin and the audience.
My take-home message is, if you can have within your group a systematic way of going about round where the same things are brought up every single day in a systematic way with the entire healthcare team, including, hopefully you can have the nurses, social workers, and so on there, clinical pharmacists if you have them, that really make your rounds more efficient and actually impactful at the end of the day.
Well, thank you so much for sharing your time and insight. Thanks again for coming back on the show.
Thank you so much, Kevin.